Thank you. Corey Walker here from Cedars-Sinai, and thanks to Dr. Snyder and Dr. Bisson. This has been an amazing meeting and such a unique session. It's a testament to what a great thing spine section is. So I'm going to be talking about something that's near and dear to my heart, treating the golfer's spine. Here are my disclosures. So I actually grew up in upstate New York, in Rochester, New York, and spent 8 years caddying. Even while I was in med school, I was working on the weekends and grew to love the game. I caddied at a world-famous course called Oak Hill, and it was just such an amazing experience. And so it's really cool to talk about this. And one of the things is we're going to talk a little bit about treating elite level golfers, but also the average golfer. But interestingly, amongst high-level golfers, back injuries are the most common injury that's reported in the literature. 20 to 30% of golfers have some sort of severe back injury at some point, and so it's a very common thing. And it's largely because of some changes that have happened in the way the golf swing has developed over the years. Tiger Woods ushered in this very compact swing that was quite different from that of the decades past with Jack Nicklaus, which was a much smoother, gradual, wavy swing where they developed this incredibly tight swing that was built around deriving potential energy through torque. And so what the players would do is they would use a fixed base with their hips and then rotate their shoulders. And the differential between their shoulders and their hips created this potential energy that could then be unleashed to drive power through the downswing and create force through the entire swing. And so this generates an enormous amount of downward force on the discs in the lumbar spine, and it also creates a unique amount of torsion and axial rotation. And when we look at this, this has been studied in kinematic studies, and actually they've done finite element analysis and shown that the amount of force on the lumbar discs is about 8 times that of the body weight standing, which is comparable to what we see with a lineman hitting a sled in full NFL full contact practice. So you can imagine this happening over and over and over again and creating disc problems. And the amount of lordosis you have is will change this, and it's been studied that your posture affects this. The L5S1 disc tend to take the most load, but it's distributed through the lumbar spine. And when this is done several hundred times a day, this causes notable disc injuries, which have been documented in the literature amongst elite golfers. We wrote a paper on this in JNS a few years ago talking about this repetitive trauma to the disc that happens, and the amount of force that's there it's unique. No other sport creates that much torsion on a regular, repeated basis, and the discs were not developed to do that. They were built to take axial loading. So, this is something that we've seen grow and is becoming more and more popular or common amongst elite golfers. If you do encounter a high-level golfer in your clinic, one of the things I've learned from studying all these papers is that there's such a reliance on the paraspinal musculature in the golf swing. And actually, there's been quite a few studies that show imbalances in these muscular profiles will actually predispose golfers to injuries. And so if you have inequality in certain muscle groups, you're more prone to having back injuries. So if you're going to treat them, it's the utmost importance that you try to preserve the paraspinal musculature as much as possible. So using minimally invasive approaches, endoscopy or tubular approaches is probably helpful. If you do need to fuse someone like Tiger had multiple decompressions, but then went on to need a fusion for discogenic pain, using an anterior approach that's muscle preserving, such as an A-lift, might be advantageous. And if you're seeing a young golfer who has preservation of their facets and discogenic pain, you can consider arthroplasty. It's not a contraindication to doing motion preservation. But for most of us, we're going to be seeing one of the 55 million golfers in the United States who plays average, typical Joe Schmo golf. So more than 1 in 10 people that comes in your clinic is probably a golfer at some point or even a little bit. So it's a consideration for all of us. And most injuries can be treated non-surgically. The core tenets are hip mobility, core strengthening, and improving your thoracic rotation. Actually, the National Spine Health Foundation has a tremendous website dedicated to this. I urge you, if you have any patients that have back problems, to go on there. There's all sorts of stretches on there, different tools and ways that they can treat treat their backs non-operatively and really help their care. The Titleist Performance Institute has a series of active decompression stretches that they have on their website too that's really helpful. And so all these things can be really helpful. And I often tell patients, if they're experiencing back pain, maybe they need to go see a pro and talk about making some changes that unload some of that force on their spine. It may take off a few yards off their swing, but for the average golfer, that's better to be pain-free than hitting the ball 10 extra yards. So they can make changes that actually work in reverse from what we've seen with the modern golf swing. The most common thing, though, people want to know is, okay, I operated on a golfer, when can they go back? And I think that if you look at this grossly, there's been some broad recommendations. NAST did a survey of about 523 respondents and showed that most people feel that about 4 to 8 weeks for a decompression is appropriate and 6 months for a fusion. I don't necessarily, in my opinion, this is not quite granular enough. So looking at the data, you can see for different pathologies, there may be different paths. So for someone with a disc herniation getting a discectomy, my number one concern is the risk of reherniation as the annulus repairs and heals. The last thing we want to do is be putting more force and predisposing them to needing another reoperation. So I'm a little bit more cautious with these patients. Watkins Sr. published a paper that showed about 90% of these people can go back at about 5.5 months. So, conservative treatment with these patients is really important. You don't want to let them go back too soon and end up with an injury. So I try to have them do dedicated physical therapy, starting at about 4 weeks, do that for a few months. And then at about 12 weeks, very light swings with a cap on the number of swings that they do with eventual ramp up by 5 to 6 months. With laminectomies for stenosis, this is a little bit less of a concern. We're not worried about reherniation. So I let them get back quicker. And usually by 12 weeks, I'm letting them kind of return to play. For cervical and lumbar arthroplasty, I think that the concern here is making sure that the disc devices are integrated and stable. And typically this is about 3-month time period. Also, if you do a lumbar disc replacement in a younger patient, you want to make sure they have time that their rectus muscle can close and the fascia is healed so they don't get a diastasis. But usually by about 3 months, we get x-rays, make sure all the hardware looks good, that their pain is improving. And then by about 4 months, I let them start to work back into full swings. With fusion, it's very important that we establish the fusion has occurred. So this delays the pathway. If somebody's really adamant about getting back to golf, I like to establish radiographic union. I want to obviously also see that their symptoms are improved and they're getting better. So I start the same sort of timeline with physical therapy at about 3 months. And then at about 5 months, I let them do some light swings, but not full swings until we get that CT scan and establish that they're fully fused. If they're not, we'll give them more time, obviously, but I would be reluctant to let them start swinging and playing a lot of golf until we see that. Lastly, if a patient has a spinal deformity operation, everybody wonders, is this a death sentence? Can I ever go back to playing golf if I need a big operation? There's not a lot of evidence. Dr. Zuckerman had a nice paper here that showed their series of patients that were able to get back with variable amount of time before they were able to, but we're talking at least 6 months, probably more closer to 12 for most people. But it's possible, and I don't think that you should tell somebody who's getting a deformity operation or complex multi-segment fusion that they can't. I think they need really, really to be established that they're fully healed. You don't want to put them in a situation where they could end up with hardware failure or something else. And they obviously need to make sure that their core is strong and built up before they go back to doing this. This is a study from HSS that showed about half of patients with deformity were able to get back to golf. So I think that, obviously you have to be cautious and it's got to be the right patient. But altogether, these patients should be able to go back to golf too. So without further ado, we'll get on our next topic. But thank you so much for your time. I appreciate the invitation and have a great day.
Of course. Could you comment about your paper, which I share with patients, by the way, just to let them read it directly from the man, about the specific pathology that you see in the golfer's spine?
Yeah, so it's interesting. There's actually a few papers that show asymmetric osteophyte formation on the trail side of the spine. So when you're swinging, the side that takes the downward lateral flexion force, and you can actually see that in people. Obviously, people's spines are going to degenerate differently. And depending on their lordosis, how they swing, I think it's very common to see annular tears and disc injuries. And often we know that most of those don't need surgery, but definitely a significant number of pro golfers needing microdiscectomies and treatment of L4-5 and L5-S1 disc herniations. So I think that's probably the most common thing. But also, like, after that injury has occurred, the disc is never really perfect again. We know that. So I think that you also have to keep a keen eye out that, like, if they're continuing to have discogenic pain, which is not radicular pain, but, true loading pain, worse with rotation, and that's their passion, then maybe you need to consider doing something more, what we probably wouldn't do in another person, but, maybe doing something more durable with their disc with reconstruction. But, special considerations for each person, depending on their level of golf and whether they're professional or where they want to go with it.
Great.